I am so excited today to be joined by Dr. Riemann. He is one of the most sought after consultants in the OCD world. I was picking his brain before this webinar started on my own growing practice. So today we're going to be speaking about residential care and how to know when residential care is appropriate for yourself or your family member with OCD. So, just so people understand, the incredible accolades and accomplishments of Dr. Riemann, I'll briefly share. He is a senior consultant working with various behavioral health companies and academic institutions. He is a former president of philanthropy, research, and clinical care at Rogers Behavioral Health. He worked at Rogers for 26 years. He's also been chief clinical officer and system chief operating officer. Among many responsibilities while at Rogers, Dr. Riemann launched and developed the OCD and anxiety service line with programming at the inpatient, intensive outpatient, partial hospital, and residential levels of care. That means that they were serving about 800 OCD and anxiety patients per day. So I cannot ask for a more experienced, more prolific thought leader in our field of OCD. And thank you so much for joining me today.
I'm excited to join you today and looking forward to our conversation.
Wonderful. So I just want to start with a very brief explanation. What is the difference between inpatient and residential?
Yeah, that's a great question and a super important one. There are some similarities, but there are some very, very important differences. In 2024, inpatient hospitalization in the United States is really to try to stabilize an acute psychiatric crisis, right? Someone is deemed a risk to themselves or someone else. They are in real trouble. And we put them on an inpatient unit to try to stabilize that crisis. It's really not meant to treat the underlying things that cause the crisis. It's just to stabilize them, get them safe, and then move them to a different level of care. Generally, these are locked units. You cannot just come and go as you please. And the lengths of stay maybe are 4, 5, 6 days just to kind of stabilize that crisis. Residential, on the other hand, it is staffed 24 hours a day, like an inpatient unit, but you cannot be deemed at risk to yourself or someone else because that would, disqualify you for residential and mean you'd have to go to inpatient. They are not locked units. In theory, you could admit into a residential program and 3 hours later go, this isn't for me, and leave. And the lengths of stay are much longer. So generally in residential OCD treatment, a length of stay might be 45 to 60 days. And it is an immersion treatment experience. It is to get them a high level of treatment to overcome their very severe and complicated OCD and potentially other comorbid kinds of conditions, other things that trouble them, such as depression or other anxiety disorders. But there's a big difference, right? One is more of a stabilization model, inpatient. The other is a treatment model for really severe and complicated conditions.
Thank you so much for explaining that. And
Yeah,
then let's define one more term that you and I will probably be using, therapeutic dose. What does
yeah.
therapeutic dose mean?
Another great question. Yeah, and I'm a big proponent of this. We talk about dose all the time when referring to medications, 20 milligrams of this, 40 milligrams of that. But rarely does dose come up when we're talking about psychotherapies. And
Mhm.
there very much is a dosage effect of how much high quality treatment someone needs to get better. And so the idea is the more severe and complicated, let's just say someone's OCD is, the more high quality treatment they need to get better, right? And so the therapeutic dose is just, for example, mild to moderate OCD can respond to high quality outpatient treatment, right? 1 or 2 hours a week. Somebody who's more in the severe to extreme, they just need more treatment. And if you have a really bad headache, you may take one aspirin and it doesn't help your headaches. It doesn't mean aspirin doesn't help headaches. It just you didn't take enough. And in this case, sometimes some of our clients will try high quality ERP, but only get 1 or 2 hours a week, and then kind of throw the ERP baby out with the bathwater and say, well, I tried that and it didn't help me. Well, you did get high quality treatment. And of course, that's one of the aspects you have to evaluate. Are you getting high quality? But then did you get enough quantity, right? And that's where, an IOP, an intensive outpatient program, may provide anywhere from 8 to 15 hours of ERP a week. Partial hospitalization programs, PHPs, they may provide 20 or 25 hours of ERP a week. And then residential treatment, these places where it's really meant to help people that with severe and disabling, impairing levels of anxiety and OCD. They're not only going to maybe provide 25, 30 hours of ERP a week, but then they have that 24-hour support and staffing to help them manage their symptoms and their issues that they have. Yeah, but there's a real dosage effect, and I'm a big believer and a big proponent of that. When you're thinking about OCD treatment, you got to think about the quality and the quantity.
Wonderful. Yes, I fully agree. And I wish we talked more about therapeutic dose in our field. So just for our listeners who maybe aren't familiar with the term ERP, that means
Yep.
exposure response prevention therapy. Could you briefly describe why a large quantity, why you would possibly be doing 25 hours a week of some type
Yeah.
of therapy? Because I think for people who are outside of our field, they don't quite understand how one person
Yeah.
can engage in that much therapy.
Yeah, great question and good point. And I would just say before getting into that, that I do think that that dosage effect goes beyond just OCD and ERP. I do think that that is also relevant to other conditions such as eating disorders or whatever it might be. But so it's not just an OCD issue, but the idea again is, the more severe and complicated someone's OCD, generally the more exposure territory you're going to need to cover. So someone who's an outpatient, may have 6 or 7 different primary symptom areas that need to be addressed. Somebody who's severe or extreme, they may have 20 areas that need to be addressed. So the more symptoms, generally the more exposures, the
Mhm.
more exposures, the more treatment you need to be able to conduct those exposures. And then also, in addition to just kind of the scope of the condition being bigger and therefore requiring more treatment, because of their severity and the intense anxiety they experience, they just need more assistance getting through their exposures. So, and I call them outpatients. And what I mean by that is, somebody whose level of severity, is appropriate for a 1 or 2 hour high quality ERP intervention. The idea is again, the more they can work independently. You can have them come in, you review their homework, maybe you do an exposure or two, and then you assign homework for them to do over the next week. And they're able to do a lot of this independently. The more severe and complicated somebody's OCD is, generally the more therapist aided or assisted exposures they need. It's like you have to kind of prime the pump with them more in session, which means you just have to have more sessions. You have to have more time, and they need more assistance with the second part of treatment. I mean, you think about OCD, it's a two-part problem, obsessions and compulsions. It requires a two-part solution, exposure and response prevention. Not only do they need more assistance in conducting their exposures, but they need a lot more support in doing the response prevention or the ritual prevention part. If you think about it, it's do this, that's exposure, and don't do that, right? That's the ritual prevention piece, right? Touch this, don't wash it off before or wash you off after. And so as the more severe and complicated the OCD, the more help they need in doing this, the exposure, and not doing that, the ritual prevention.
Absolutely, absolutely. And just to give a little bit more color for listeners who aren't as familiar with exposures, they are based on a fear hierarchy that the therapist and the client together create. And whatever the fear target is, you are slowly and methodically working up. So
Yep.
you don't want to be just starting at a 10 in a 1 to
Correct.
10 scale. I
Right.
know Rogers, you guys use 1 to 7. That confuses me. But But in the 1 to 10 scale, you want to be gaining mastery with the 2s and the 3s before you move on. Now, if you're in an outpatient setting and you're still in 2 and 3 territory, like 2 or 3 months in, you might start to lose faith that the exposure response prevention approach works, because you're still watching movies about aneurysms rather than being in the cardiac unit of a hospital, which is higher up on your scale.
Yeah,
So
yeah, yeah.
Dr. Riemann has, when he's working with clients, he has a lot more access and able to create. I would imagine at Rogers, you don't create one fear hierarchy. There's probably 6 or 7 based on the different themes and the different targets.
Yeah. Yeah, and just to be clear, obviously I'm not at Rogers anymore, so I mean, yeah, I don't want people to think that. And in the program, the residential program that I'm working with right now is with Ascension of Illinois in the greater Chicago area. But the methods, of course, having developed the Rogers program, are very, very similar. But we always have only one hierarchy. I mean, just to clarify, but there's going to be a mixture of symptoms, right? And so, somebody might have some concerns with contamination and then hand washing. Somebody might have some concerns with doubting whether they did something or did something correctly. And so they might check stoves or locks or light switches and these kinds of things. They might have some religious obsessions and praying compulsion. All of those different symptoms are going to be targeted in treatment. All of them would be on the same hierarchy. And to your very important point, they're stratified by how challenging they would be for someone to do. Flooding is not an effective way to counteract phobic fear and avoidance. And a flooding on your 1 to 10 scale would be starting people off in their 9s and 10s. Well, how many people are going to be willing and able to do that? I mean, very, very few. So this graduated nature or hierarchical nature of doing exposure, starting with something that's challenging but manageable, is really the effective way to go. And the whole point back to dose, the more symptoms someone has of their OCD, the more exposures they're going to have, the bigger the hierarchy they're going to have, and chances are the more support they're going to need.
Amazing. Wonderful. So what would the typical end-to-end experience be in residential treatment for OCD?
Yeah. Yeah. So typically in a residential program, and keep in mind, I think it's super important to realize that there are many, many residential programs out there. And of course, the vast majority of them don't focus on OCD. And chances are those programs aren't going to be very helpful with someone with OCD. They're not going to be doing ERP, for example. So you really want to carefully vet, the residential service provider to make sure that they do indeed specialize in this, and they are going to be providing a very high dose of ERP, right? But the end-to-end experience, I mean, these programs are really built for people who are very impaired and disabled by their OCD. They're not working, they're not able to go to school, or they're kind of sadly barely kind of just hanging on. And the good news is the vast majority of OCD patients won't need that level of care, but there is a percentage, and it's a sizable one, who it just gets so bad that they do. And so they come in and their lives have kind of come to a halt at that point. And they're, again, the average length of stay for the most part for the recognized residential programs, somewhere between 45 and 60 days with a lot of variability. Some people are able to accomplish their goals in less than that. Some people need more than that. But keep in mind, in a residential program, you're providing 24-hour care, which is a very intensive level of treatment. You never really finish what you start. And what I mean by that is your goal is to get them to the point where they're no longer disabled. Your goal is to try to get them from the severe range, let's say, to the moderate range of OCD. Great improvement, life-changing improvement. But at some point, you get them better enough that they no longer need 24-hour care, right? And it would be unethical to continue to provide them care when they again are now in the moderate range of severity. So the kind of the end-to-end experience is, hopefully then the vast majority of people who go through this experience, again, come in at a very high level of severity. You're getting significant, meaningful, life-changing reduction. And then at that point, you do have to discharge them to a lower level of care. And depending on how much progress they've made, or where even, I mean, just their accessibility, maybe they go into an intensive outpatient level of care to kind of help finish the job. Or maybe they go to a practice such as you provide to
Mhm.
again finish the job. But you know, you never in a residential facility, you never treat them to the point where they are asymptomatic, because then you have kept them in a high level of care longer than they needed to be. If that makes sense.
Absolutely, absolutely. And there's a concept known as step up and step down. So
Mm-hmm. Yep.
oftentimes we are going to be on a wait list, or we won't have a bed available right when we need it. And so
Yep.
there are reputable outpatient clinics
Yep.
would be able to prepare you for that residential treatment.
Yep.
So
Yep.
this is tricky. What advice do you have for families who are considering residential treatment, but their family member is not on board?
Yeah, that's a great question, and unfortunately a pretty common problem. You know, I think just first and foremost, from a family perspective, you know, keep in mind that dose issue. And so if your loved one is receiving 1 or 2 hours a week of high quality treatment, so that's the first thing. Are they even getting ERP, right? Because if they're not, then you got to get them to a provider such as yourself that can provide that. Is
Mhm.
it high quality ERP? Well, how do you know?
Mm.
You know, how long have they been with the clinician, and do they have an exposure hierarchy yet? You know,
Mhm.
well, they've been seeing them for like 10 weeks and they haven't started exposure yet. Okay, time out. That's a red flag to me, right? Before I went to Rogers, I was an outpatient provider. I started exposures like in the second session, right? I mean, after I did my evaluation, you know, we started getting going. So, you know, it's again, are they getting ERP? Is the quality of it good? And let's just assume those two boxes are checked. Then it's a quantity thing. And you don't necessarily have to go from 1 or 2 hours of outpatient high quality treatment to residential. I mean, maybe the appropriate step up to, you know, as you use that term, would be an intensive outpatient program, right? You know, there's plenty of people who need more dose than outpatient who still don't need residential. I mean, they just might need, you know, again, the IOPs are typically 8 to 15 hours a week. Still a lot of treatment. On the other hand, it could be such a crippling situation that they do need to just go from outpatient to residential, or say someone is floundering in an intensive outpatient OCD program. Obviously, that next step up. But you know, I think first of all, you just kind of evaluate what are they getting, and are there some changes that we could make to improve the outcomes just in this level of care by maybe seeing somebody else who knows what they're doing. You know, then the idea is you got to vet this very thoroughly and carefully. Again, there's only a handful of recognized residential providers in the OCD space. Obviously, the programs, you know, that I had developed previously, this program that we're working with at Ascension. You've got the McLean program, obviously outside of Boston, long-standing reputable people. There are other companies, you know, that are getting into this space that are kind of getting their legs underneath them, and so there are resources, but you've got to kind of choose carefully. And you know, generally when a person has to go into residential, again, their lives have just kind of really come to a stop, right? I mean, they're really just not able to function very well at work, at school, in their relationships. Um, you know, they're, like I said, they're really disabled at that point, and you just want to choose wisely. I think so many times people might spend more time picking a plumber than they do their mental health care provider, sadly. And you need to just, you know, really do your homework, ask a lot of questions. How
Mhm.
many OCD patients have you seen? You know, what methods do you use? You know, you want to hear a lot. Well, how many? You know, dozens or hundreds or thousands or whatever the provider might be. And then you want to hear that magic term ERP, obviously. That is the gold standard treatment, no question about it. And you know, of course, then the other big thing is insurance coverage, right? I mean, and in particular, as you get into intensive levels of care, whether it's IOP, intensive outpatient, or residential, they're costly levels of care to provide. So the fees are high, and you want to make sure you got insurance coverage, or it can get costly in a hurry.
Absolutely. And I'll say I have personal experience with vetting clinicians looking for someone to help my own daughter. And I can't tell you how many times I have seen OCD on someone's website. And then
Yeah.
I ask them, how do you treat OCD? And they say, talk
Yeah.
therapy.
Yeah.
I agree with you, Dr. Riemann. That's a big red flag. You want to hear the word ERP. You want to hear them talk about exposures. Stylistically, there's different ways of doing ERP. There's different types of fealty to the standard of the therapeutic process. However, the concept is the same.
Yeah.
The two-step of you phase the fear and you don't do the compulsion. It's
Right.
really the concept of it is actually quite simple.
Yep.
So what would you suggest? Because, to go back to that question of the person who needs the treatment not being on board with residential.
Oh,
For
yeah.
a lot
Yeah.
of us with OCD, we have agoraphobia or social phobia or
Yeah.
fear of being away from our family. And so
Yep.
the very concept, just even
Yeah.
if we did no other exposure,
Yeah.
residential would be an exposure
Yeah.
for us.
Yeah. 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 No, thank you for reminding me of that part of the question,
Mhm.
which I failed to address. Sorry about that. But yeah, it's a common problem. And I think, my suggestion to families first and foremost is provide them with as much information as they possibly can. There
Mhm.
are myths about what ERP is and what it's not. Okay. And some of these myths, frankly, have gotten stirred up with some of these television programs that, get very sensationalized and get into some really extreme stuff that's just not what you and I do in reality. So what is ERP, what it's not? What is residential treatment and what is it not? It's not a locked unit. You have the ability to leave at any time. What is it going to look like? And so providing information, the International OCD Foundation is a tremendous resource for what is OCD, what is ERP, and all of these other kinds of things. Um, and then, frankly, what I always have suggested is have your loved one call me, right?
Mhm.
Talk to me. There's no obligation, there's no strings attached, there's no fee for it, there's no obligation that doesn't obligate you to come into treatment. I'll answer any questions that you have, right? Um, and any provider should be willing and able to do that. Certainly, these residential programs are going to be willing to do that. And I've always kind of said, look, if they're not willing to call me with no strings attached to talk about their condition and to talk about this intervention, chances are we're probably not going to get them to come into treatment, right? Um, Tour the place, go there, walk around, take a look at the place, meet some staff members. And then, the bottom line is after doing that kind of thing, after providing information, maybe after calling the provider and talking to them, there's still a no-go. Really kind of the message that I always have for them is, so basically what you're telling me is that the treatment is worse than the condition, right?
Mhm.
Because that's really what you say when you say, nope, I'm not doing that. You're
Mhm.
basically saying, so you think going through ERP is worse than having this really bad crippling OCD? And it kind of gets them to think about things a little bit. And but not everybody. It is a big commitment. Don't get me wrong. I mean, going to Chicago for 45 to 60 days when you live in Atlanta, Georgia, and you got a 2-year-old child at home. I mean, that is a big, difficult decision, but
Mhm.
it's an investment today for relief tomorrow.
Absolutely, absolutely. And to, reveal how we handle it on the outpatient side is I actually do exposures around the program. And so we
Mhm.
do imaginal stories about the program. We look at photos. I ask clinicians, whatever clinician will probably be assigned to have a phone call. And this is working up to
Yep.
that moment of actually
Yep.
able to like be in the program. Sometimes
Yes.
we even visit um,
Yes.
the program one or two or sometimes three times before
Yeah.
any commitment is made, because we do want to regulate the nervous system and prepare for that action.
Yeah, I mean they're anxious, right? By definition, and they know you're going to have them do the things that make them anxious. Well, who would want to do that? I mean, so it's natural, in my opinion, that there would be some reservation. And that's why, again, you're kind of doing some myth busting, right? I can't tell you how many people I've talked on the phone with who their idea in their head of what we were going to do and how we were going to do it, it was 180 degrees removed from what we were going to do, right? They don't understand that we're not going to flood them. They don't understand that, we emphasize this graduated nature of exposure. They don't understand that it's our job to build something that's challenging but manageable, right? I mean, that's the mantra that we always have in these programs. The idea is, again, it's a two-part problem with a two-part solution. So we've got to create a treatment plan that they can comply with both parts of the solution. It's not just, can we get them to do this, the exposure part, but we have to simultaneously, if you will, get them to do this and not do that. So we have to get them to think those thoughts and not pray. We've got to get them to do this and not check. We got to get them to do this and not wash. And so the combination of it being a two-part problem, you got to get compliance with both of those. So it's super important, as you mentioned before, to kind of create this graduated kind of thing. We're gonna ask you to push yourself forward, but to a manageable extent. It's one piece at a time, not trying to take care of the situation right out of the gate. That never works.
Absolutely, absolutely. So I feel like you've answered this question in different ways, but
Okay.
I want to distill down to one central point. What would
Okay.
be what would be like your golden nugget of advice for families or persons who are currently looking at residentials for OCD and are sort of unsure of what's the right choice?
Yeah. Yeah. I think, again, do your due diligence. Spend some time vetting your options. There are not many, recognized residential providers. You want to make sure you're tied in with one of those. How do you know? Go to the IOCDF website, call them up. What does your search produce on the IOCDF website? Call those places, see what they do. There's a couple of other important things to think about, even within those recognized providers. How long is it going to take me to get my loved one in, right? I mean, sometimes there's wait lists. Is my insurance going to cover it? There's all sorts of just kind of practical kinds of things that have to get sorted out. But uh, there is this level of care, this high level of care with high levels of expertise. So you're getting high quality and high quantity. And sadly, that is what some people need, right? And don't throw the ERP baby out with the bathwater. Don't also be fooled yourself that, well, we tried that and it just didn't work. Well, you just didn't try enough of it, right? And so that dosage effect, right, has got to be kind of kept in mind. But um, I think touring these places, is a really good idea. And it's a big decision for, not only the patient themselves, but the family. I mean, this can't be taken lightly. It's a very important decision, and just do your due diligence. I mean, that's my biggest advice for them, and make sure you understand your insurance coverage. Make sure you understand what, if any, out-of-pocket costs there's going to be.
Mhm. So thank you so much for that advice. We're at time, unfortunately. I feel like I
Okay.
could talk to you all day, Dr. Riemann. Um, I am honored to have had you
Thank you.
on our podcast, and really excited to see if any questions come up for Dr. Riemann. Please put them in the comments,
Sure.
send them our way, and we will work on getting those answered.
Yeah,
Thank you
be
so
happy
much.
to. Absolutely.
Wonderful. Take care.
Thank you so much. Bye-bye.
Bye.